So it's so good to have you joining us today for our program. We are going to be talking about progressive supranuclear palsy. That is a mouthful. My name is Anissa Mitchell. I'm with PMD Alliance. I am so glad to bring this topic. I know that is something people have requested before, and so we're going to be doing a little bit of a deep dive today. For those of you who are not as familiar with this topic, it is a neurodegenerative brain disease. It's similar to Parkinson's, and we consider it an atypical Parkinsonism. And we are going to be diving into what exactly that means, how it shows up in terms of symptoms. I know it can impact walking and movement, balance. So we have with us an expert on this particular subject, Dr. David Shprecher. He is a movement disorder specialist. He is at Banner Sun Health Research Institute in Sun City, Arizona. He's also a clinical associate professor at the University of Arizona, and he has graciously offered his time to give us a great overview of what PSP is, what it looks like, how it's treated, and what are some things that might be coming for those with this diagnosis in the pipeline. So I am glad to have you with us, Dr. Shprecher, and I'm going to hand this over to you.
Right. Just bear with me while I pull up my slides and share them with all of you. Okay. So let's see if this works. All right. Just everything showing okay? Great. All right. Well, thank you so much for the opportunity. Yes, progressive supranuclear palsy is a mouthful. So we generally use the acronym PSP. When trying to make light of a difficult situation, I sometimes tell people, some kids also think of PSP as the PlayStation, and that's the PSP you want to have. Another famous figure, I'm not sure if you're aware, but there's a very famous actor and comedian who had PSP, who, when he was announcing his diagnosis to the world, um, he was kind of estimating that only 1 in 100,000 people get PSP. It's somewhere around 1 to 10, depending where you look. But he was trying to say, I understand only one person 100,000 suffers from this disease, and there are also 100,000 members of the Screen Actors Guild. And therefore, it's very considerate of me to take on the disease myself and protect all of you from this fate. This is the actor who played the original Arthur, the alcoholic millionaire. Now in the remake, it's the alcoholic billionaire, but that was Dudley Moore, who unfortunately died of complications of PSP in the early 2000s. So I wanted to take a little bit of time just to explain how PSP is diagnosed and why there are still some unique challenges in diagnosis, because we don't have definitive tests for that. We have to diagnose based on the story that you give us, the history, and then your exam. And then what is the state of the art right now in terms of treatments available? And then what's in the pipeline that can provide hope for future patients with PSP? So I always try to, I know some of you have heard me speak about this before, but I just try to explain the term Parkinsonism, because a lot of people, when they finally have a diagnosis of PSP, are told that you have a typical Parkinsonism, or we don't think you have Parkinson's, we think you have a Parkinson's plus syndrome. So what we're talking about here is there are symptoms related to trouble walking, trouble moving, or tremor, where on the actual exam, we appreciate slowness of movement, what we call bradykinesia, as well as tremor or muscle rigidity. There also may be problems with impaired postural reflexes, so balance problems. And if we see at least two out of these four features on the exam or a combination on the exam and the history, then that means we have the symptoms or the exam findings of Parkinsonism. But then we have to decide what's causing it. And sometimes it can be side effects of a medication. Sometimes it could be um, damage to the nervous system from toxins, for example, manganese from welding fumes. But when we've kind of ruled out that other stuff, then we're looking for red flags that would tell us this isn't really characteristic of what we see in textbook Parkinson's disease. And kind of the top three other types that are caused by degeneration in the brain, they each have their own acronyms. So dementia with Lewy bodies is DLB, and that's one that causes dementia from the beginning, but also hallucinations, acting out of dreams while asleep, spells of profound disorientation and attentiveness. The other acronym, MSA, multiple system atrophy, always causes autonomic problems early on, like unexplained bladder incontinence or low blood pressure standing up, but often also causes coordination problems, so problems with the cerebellum, known as ataxia. And then the third acronym, CBD, it's not the medicine that we like in our gummies or, the marijuana shops, but it's corticobasal degeneration. And it usually causes profound problems, more mainly just on one side, much more than the other, where you actually forget how to do things, called apraxia, or they're cramping spasms, severe cramping up, called dystonia, or something where the arm just has a mind of its own, called alien limb. But the main one that we're here to talk about is PSP. And so we'll go into detail about these red flags and then how they lead to a diagnosis. And sometimes it's a diagnosis of exclusion because we still need to review other medicines. And people don't always see us in a vacuum. Sometimes they're taking medicines that also can cause symptoms that resemble Parkinson disease. So a lot of the mood stabilizers, the antipsychotics, but also valproic acid or Depakote, can cause problems with walking and balance and symptoms that resemble Parkinson's or that make the underlying condition much worse. So there's a lot of nuance to communicating between the neurologists and psychiatrists in those cases about what to do and what the likely diagnosis is. Another important problem is when somebody mainly has lower body symptoms. So they shuffle when they walk, they have balance problems. That is a big red flag that this is not typical for Parkinson's disease because Parkinson's usually starts with upper body involvement and it's much worse on one side than the other. The exception is if there's just tremor at rest in the leg. But when we just see problems in the lower body, we usually need a brain scan. If you can't do an MRI, we get a CT scan because there are two other important problems we need to look carefully for called normal pressure hydrocephalus or NPH and vascular Parkinsonism. And some people can have more than one thing going on. So it's not just check in the box, this is what you have, and there's nothing else. And that's what's really complicated about neurology is there's not a just a definitive test like you get a blood panel and find out, okay, here's your kidney function, here's your liver function, sugar's normal. There can be multiple problems within the nervous system and more than one cause. Another way that your doctors should be thinking about your illness is if they've got the brain scans, they decide there's not necessarily a circulation problem in the brain, so vascular. They don't see normal pressure hydrocephalus, so water on the brain, and they're convinced there's degeneration in the brain. They're really thinking about two main causes, and it has to do with the proteins in the brain that aren't being recycled properly. So one protein is an important building block of the nerve cells in the brain called microtubule associated protein tau, or just tau, TAU for short. So both PSP and CBD, if someone donated their brain for research, we would see clusters of this protein kind of clumped up in certain cells within the brain. With Parkinson disease, with dementia with Lewy bodies, and even with multiple system atrophy, there's a different protein called alpha-synuclein. And in Parkinson's and dementia with Lewy bodies, we see it as a collection in the brain neurons, the brain cells called Lewy bodies. In multiple system atrophy, it's mainly in a different type of cell called the glia. But those are really the two main um, kind of horsemen of the apocalypse. There are other proteins that accumulate in other degenerative illnesses outside the scope of this talk, amyloid and Alzheimer's disease, and something called TDP43, and Lou Gehrig's disease, and some types of frontotemporal dementia. So they're kind of four main proteins we as the neurology specialists think about. But PSP, it's the tau protein. And we always teach people in medical school, if you see a certain triad, you need to think really strongly about a certain condition. And when it comes to PSP, if you have this triad, you are more than 98%, in some studies, 99% likely to have PSP. So it just having the symptoms alone in the absence of other things that explain it, like, manganese fumes, welding, antipsychotic meds, and so forth. If you can't look your up and down with your eyes, if you're falling all the time because of impaired ability to react when you lose your balance, so postural instability, and then if you have Parkinsonism, that's similar on both sides of the body, it's more stiffness in the neck than the arms, and it's not responding to levodopa, or the response is really poor, like needs a really high dose or is getting worse over time, you are greater than 98% likely, just based on the symptoms alone, to have PSP. There's no definitive test. It's not like you can get a brain scan and based on a DAT scan or an MRI or anything else, have that tell you, pat you on the back and say, the neurologist was wrong. So this is where it gets tricky because some doctors aren't comfortable making that call and deciding if you have all three. And we also have maybe only 20 or 30% of people have all of these features at the beginning. So that's the challenge. So it's estimated only about 30% of people with PSP have the classic form of PSP called Richardson syndrome, where we can say with greater than 98% confidence you have PSP. All the rest actually will start with much more subtle features. So their eyes are a little bit slow up and down following a target. It may look like Parkinson's in the beginning, but then later on the other features declare themselves. That type we call the Parkinsonian variant, and at least a third of people have that. That can really throw everyone off because in the beginning we think it's Parkinson's, and then later we find out it's PSP. Another challenging one, and it's very frustrating for people because we don't have kind of a standard way of saying the accuracy of diagnosis, is the type where it starts mainly with lower body problems, mainly just freezing of gait. So when you try to walk, it feels like your feet are stuck in place. And even though we're giving you tons of Parkinson medicines, it doesn't get better. That's almost never Parkinson disease. If your first symptom in the first 3 years is mainly just gait freezing and your upper body is working fine, if we don't see normal pressure hydrocephalus, we don't see circulation problems in the brain called vascular Parkinsonism, as that evolves over time, that almost always turns out to be PSP. And it's very frustrating for people to hear that because they don't have the classic features, what we call Richardson syndrome, or only a very experienced neurologist who knows what to look for can point those out. So just they're very subtle slowing when they try and move their eyes up and down between two targets, or very subtle slowness of movement on with the finger taps and open close hands and so forth. Another way people can start is it's mainly just language problems or changes in behavior. So uncharacteristic impulsiveness or inappropriate social behaviors or problems with language. So Dudley Moore, when towards the end of his career, Barbra Streisand had to fire him from a movie called The Mirror Has Two Faces because excuse me, he was forgetting his lines. So he was already having subtle language problems. So someone who was perfect at memorizing lines and lines for movies couldn't do it anymore. For some people, though, it's just the cognitive in the beginning. So it starts with just either mild cognitive impairment or frank dementia in the frontotemporal dementia category. And this is the problem is PSP is likely very much underdiagnosed because only about 30% of people have the classic features. So there are some new criteria that we're starting to use that are very complicated that were recently established just in 2017 about, where we have different levels of confidence in the diagnosis. But once we start telling you, especially if you're seeing a movement disorder specialist, this is the most likely diagnosis, and all of the other possible causes are extremely unlikely, even though the confidence is lower, it's still the most likely cause. And this is where research will be really helpful to improve your confidence in what we're telling you so that we can have a special brain scan, for example, or other tests that would make you comfortable that we're not missing something else. So we're looking for not just trouble looking up and down, but whether you can follow two targets rapidly. So if you've seen a neurologist and they've never even looked at your eye movements, then you should be getting a second opinion already, because if you're falling all the time and they don't even bother to look at your eye movements, they just don't have enough time to do a proper exam. The Parkinsonian symptoms can be very subtle for some people, and it's not always the type of gait that you usually see in someone with Parkinson's. It can be shuffling, but for many people, they're actually hyper erect and really stiff in the way they walk. And it's just that they fall at the drop of a hat if they lose their balance or with turns. And then there also can be this freezing with the turns where they do a stutter step or they're stuck in place. Then we also look for cognitive problems, but mainly with language or being more impulsive, not so much in the way of memory loss. So MRI or CAT scan, CT scan, can be very helpful to look for other features. So the water on the brain, normal pressure hydrocephalus, or the circulation problem called vascular Parkinsonism, and people can have more than one cause. Sometimes there are characteristic features of either PSP or the other atypical type called multiple system atrophy. In PSP, there's a certain part of the lower part of your brain called the midbrain that will be shrunken, and it looks like a morning glory flower. So you might see the term morning glory sign on the MRI report. But that will help improve our confidence in the diagnosis if it's present, but it doesn't rule it out by any stretch if it's absent. Now, I know that there've been a lot of webinars about the SIN1 biopsy test, and I cannot emphasize enough, there has never been a single study of this test in people with PSP. So this is not yet validated to kind of rule in or rule out whether you have PSP. And one of the tricky things is, I just want to preface by saying in Sun City, Arizona, we have one of the highest ages at autopsy of any brain bank. I think it's 83 to 85, depending on the year. But in that population in the mid 80s, we've found that as many as 10% of those older individuals who had Parkinson disease when they donated their brain also had PSP changes in the brain. So it raises the question, if somebody looks like they have PSP, and then they have a biopsy test that's looking for Lewy body changes in the nerve endings in your skin that says you also might have Parkinson's, that does nothing to tell you that it's not PSP. It just gives you false hope that it's not. So this biopsy should never be used to rule out PSP. Okay. But it may be useful if we're seeing you with very early atypical Parkinsonism and we're saying, well, we're still trying to decide. You fall a lot, but we're not really sure if this is going to be multiple system atrophy or PSP. Well, with multiple system atrophy, you'd see that synuclein protein in the nerve endings in the skin on this biopsy test. But I think a lot of neurologists who just don't understand the limitations of the research studies yet are starting to mischaracterize this as just a definitive test that can give you yes, no answers. It's just another piece of information for very astute neurologists to use to help clarify all the possible causes of your symptoms. Another important test is the DAT scan, but depending where you have it done, it's not always interpreted correctly. So just having a test where they say your test is negative and therefore you don't have anything in the Parkinson's family, well, not so fast. Depending where it was done, it may not necessarily even be accurate. But also, the main role is if you have symptoms that kind of resemble PSP, like you have slurred speech, which can also be seen with Lou Gehrig's disease and a close cousin of that called PLS, progressive lateral sclerosis. It might help us look more carefully for motor neuron disease or for PLS if you had a negative DAT scan. The key is these tests are in no way a substitute for a very detailed history and exam. So if your doctor only spends 5 or 10 minutes at a time with you and has never done a thorough exam, you just need a second opinion from someone who understands how to diagnose the more complicated things. These tests do not replace a good history and exam. Now, moving on to the symptoms, we really need to think carefully when we're following a patient up and kind of go through a list. I can do this in my head because I've seen a lot of patients over the last 15 years, but a lot of people will use special scales or checklists to do this. And they'll start from the top. Do we have challenges because of the language problems or being too impulsive? And then how do we kind of go through strategies to how to compensate for that? Do we have problems where the eyes close too much and it's interfering? And then there are treatments we can talk about for that. Sometimes people say, so-and-so is depressed, but when we actually ask about it, it's something called involuntary emotional expression disorder, where they cry at a Hallmark commercial or just having a happy conversation on the phone and they cry. So it's an uncharacteristic crying or crying that's inappropriate for the situation, or even worse, laughing that's inappropriate. So so-and-so just passed away and you're laughing because you can't show the appropriate response. One of my patients would always laugh with a mouthful of food and it would spray all over the dinner table. So this can become really upsetting or embarrassing for people, and there are medicines that can help with that. But it's not depression, and it doesn't necessarily respond to antidepressants. So we need to ask about involuntary laughing or crying as opposed to depression, and then also uncharacteristic problems with anxiety. And then anxiety medicines, usually in the antidepressant family, can be very helpful. Some people who didn't have a problem before with insomnia or restless leg can start to have that once they're diagnosed with PSP. And then there are treatments we may talk about, and it may require certain medicines. Now, the swallowing problems are very important to monitor and address because, first of all, people can choke suddenly, and we want to make sure caregivers learn how to do the Heimlich maneuver. But also, thin liquids tend to go down the wrong pipe first. And so people will need to start using thicker liquids or be taught how to take small sips and tuck the chin after each sip to avoid thin liquid going into the lungs, because that can cause earlier problems with aspiration pneumonia. Now, the role of speech therapist is not just to help with speech problems, but also with swallowing problems and with language problems. So what's the difference? Speech, when we think about Parkinson's, we're training people on how to project their voice better. But with PSP, it may not just be a soft voice, but also the speech is slurred. So they're dysarthric. And people may actually lose the words for things. And towards the advanced stage, they may actually be unable to get the words out at all, but they can still point to things on a language board. So this is where some speech therapists aren't really trained on how to deal with complex or rare neurological disorders. So you want to see someone who has worked with people with aphasia due to stroke if you're trying to get speech language therapy and actually develop communication strategies to get around the actual language problems, the problems actually coming up with words or processing what's being said to you. Constipation is really common in all the Parkinsonian disorders, including PSP, and may need a bowel regimen to address it. And then bladder problems are also a common later issue with PSP. So I kind of alluded to the fact that I think when we were preparing to kind of let everyone in the visit that one of the things we have trouble with as neurologists is we don't want to kind of throw everything at you at once. We want to make sure that we've followed all the right steps to make you comfortable with the diagnosis and then give you time to learn about it. But unfortunately, all of these atypical Parkinsonian disorders, Parkinson plus syndromes, progress really fast. And so by the time you've had time to read about it, it's really scary. And we're already kind of behind on talking to you about what to expect. So one important thing to expect is most people are wheelchair dependent within about 3 to 4 years due to repeated falls. And it's not necessarily that they can't walk, but they can't walk and not fall, even if they're holding on a walker, unless there's someone directly supervising. Another challenge is people are more impulsive, not all, but at least half are. And so even though they're supposed to wait for someone to supervise, they won't do that. So if you just leave them in the car because you forgot your keys, you come back and you find them on the ground because they just got out of the car and forgot they can't walk without supervision. So direct supervision can be very taxing for caregivers and you need to plan ahead for that. Swallowing problems start to become severe later by year 5 or 6, and incontinence as well by year 6. Um, the severe cognitive impairment usually is a later feature to where people really have trouble communicating due to language issues by year 6. And it used to be the original study suggested people live an average of kind of uh, 6 to 8 years, maybe 8 years or 7 to 9 years, so 8 years on average. I think the more recent studies suggest the average person lives about 5 to 8 years from the time that their PSP symptoms start, if we're talking about classic Richardson syndrome. So we think about, when did they start falling? When did they start having trouble walking? And then calculate, we need to plan ahead that they're going to be wheelchair bound in 3 to 4 years and they're going to live 5 to 8 years. The Parkinsonian variant is a wild card. Some people live much longer. The gait freezing type as well, people can live 10 years or more. So if it's just gait freezing in the beginning, we might have a different, more gradual progress, but it's very, very disabling to be unable to walk, and that's still common with the gait freezing variant. So in terms of the medicines available, we have some practice guidelines that were recently put out by a bunch of centers that have experts across North America a few years ago. They recommended that we push the dose of levodopa to at least 1,200 milligrams a day. Many of us will push the dose much higher than that, so 1,600 or even 2,000 milligrams a day, as long as the patient is still tolerating and still looks like there's some potential improvement either with fine motor skills in the hands or with the gait freezing. It doesn't restore postural reflexes, so we need to be realistic. It's not going to make it so that you're not unsteady on your feet. And if the gait freezing does not respond, or the person just doesn't tolerate any formulation of carbidopa-levodopa, and their slow release pills we may use to help tolerate, then amantadine is something that is worth a try for gait freezing. It's hard to say exactly how often people respond, but some people do respond, and so it's worth a try. With the postural instability, we need to make sure the physical therapists understand what the goals are. So sometimes we want them to work on reducing risk of injury to fall due to falls or doing balance exercises to help slow the decline in balance. Sometimes, though, we want them to address gait freezing. And if they're not clear about that, they'll try to decline seeing you because they said, well, you've stopped making progress with the balance problem, but now we want them to work on the gait freezing. And not everyone's comfortable how to work on gait freezing. So we need to make sure that if they're not skilled in complex neurological illness, that they have someone in the group see you instead. And then with the involuntary emotional expression, sometimes antidepressants may help, but the one that is most reliable in its effect is it's a brand name drug called Nuedexta, and it's just something where you work your way up to one pill twice a day. It's just a standard dose, and most people, they can, just explain why they cry and they're not worried about it. But if some people are just really bothered, they just wish they wouldn't cry all the time at the drop of a hat. And in those cases, it can be helpful. And of course, if you laugh with a mouthful of food every day at dinner time, you got to take this. That's not feasible. We do have botulinum toxin like Botox and Xeomin, Dysport that we can inject around the eyes if the eye closing spasms are problematic. A lot of people also have this head drop dystonia with PSP or with MSA, and unfortunately, injections are not very effective for that for most people, and it can worsen swallowing problems. So we don't usually encourage it for uh, neck pulling forward. We do recommend it for excess saliva in the mouth because that can make people more prone to aspiration pneumonia, especially if they sleep on their back because that excess saliva is going down the wrong tube all night long. And usually Xeomin and MyoBlock are the ones that we're using because they're easy to get approved. They're FDA approved for sialorrhea. We usually use antidepressants off-label first line to help with insomnia because they're just safer, and we worry that the sedating ones could worsen, balance or impulsiveness during the day. But sometimes, if that's the only thing that gets them to sleep, we'll still use the stronger sleep aids. The main thing is with bladder symptoms, there's a lot of bladder medicines available, but the general teaching is oxybutynin is more likely to worsen cognitive symptoms of any neurodegenerative illness. So we try to avoid that one in any Parkinsonian condition. And you often need urologists to partner with your care team um, to come up with other strategies for bladder symptoms. With the restless legs, the same things that work in regular restless legs. If it's started in the setting of PSP, these medicines still can be helpful. So they're often used like gabapentin and Horizant are considered first line. Ropinirole, pramipexole, Nupro are second line because they have more side effect risks, but they all can be helpful. So hopefully I've convinced you that a movement disorder specialist has a little bit more of a thorough approach to the diagnosis. They usually have a little more experience with the rare neurodegenerative diseases, and they may also follow an algorithm where they're monitoring for all the characteristic features of a given atypical Parkinsonian disorder like PSP. It used to be that it was really hard to get in with one, but I would conjecture that most movement disorder specialists, because they're also involved in recruiting for research studies, if you really reach out and want to be seen for PSP within a given region, there are going to be specialists that will find a way to get you in sooner if you're persistent. And there's really no excuse anymore for us as specialists to say you have to come in person for every visit, as long as you're in a state where we're licensed. So, then we may often want to establish care because we're trying to confirm diagnosis and test your balance. But once we've established care, a lot of my patients, especially if they don't live right here in my 10-mile radius of my clinic, I'm seeing them on telemedicine. I mean, this is the post-COVID era where most of us can do that. There's a company called Synapticure where if my patient is out of state in the summertime, I can partner with them to still have telemedicine follow-up in any state of the union. And they have movement disorder specialists. So you do have access. You just have to be proactive and be persistent and then take advantage of telemedicine, learn how to use it if you want to have your care under a specialist. And the other really challenging problem is that doctors don't always work within the same health system. And so they may not necessarily copy each other in on their notes unless you remind them at every visit who to copy in. So I can't emphasize that enough. My clinic can only default send the notes to the primary care, but we sometimes have to review at the end of the visit and make sure I send a message right away to the person responsible to make sure who else is copied in. Otherwise, it just won't happen. There's just too many other things we're doing at the end of the day. So you want to make that clear at the end of the visit who to copy in. And that way, when your other specialists are following up, they know what the other people were thinking and why they were making these changes. Between the psychiatric and sleep symptoms, the bladder symptoms, the pain symptoms, you may have multiple specialists involved on top of having primary care and then a regular neurologist plus a movement disorder specialist. So it's kind of up to you as the caregiver to make sure that the team is all copying each other in and knows what the others are thinking. And the other important thing is to be really proactive with advanced care planning so that you have all your boxes checked and you already have your contingency plans for your journey with this illness, or if something unexpected happens to the primary caregiver, or if the primary caregiver is starting to feel overwhelmed. And this is where, some people will take advantage of working with social work to get advice that's relevant to them at their current stage in life and their current finances. But it's also very specific to the different region of the country that you're in. But it's so important to know in advance what your loved one's wishes will be if they get to a point where they just can't swallow safely, or if they're losing a ton of weight, would they want a feeding tube to keep them around longer? Some people say, as soon as I get to this point, I don't want to eat or drink, and then you have to honor their wishes and don't force feed them. But that's rare. I think the main question is, do they want the tube in the first place? If they get to a certain point, are you going to stop taking them to the ER every time that they fall and hit their head, every time that they have a bladder infection, because they're at an advanced stage and you don't want to put them through uncomfortable ER visits? Those are the tough conversations to start having in advance and to have on a regular basis as things evolve. But there's no one right way to plan this. This is very individualized. And the other challenge is if your loved one falls all the time, whenever they're not supervised, because they just get up and fall, then you have to figure out, how do you have a team involved that can directly supervise around the clock, because they will fall whenever you're not there to keep an eye. So I'm just going to briefly touch on kind of the genetics and research side of things. First of all, PSP does not usually run in families. However, if two first-degree relatives were both diagnosed with PSP, or if one first-degree relative has PSP and another has frontotemporal dementia or ALS, Lou Gehrig's disease, motor neuron disease, I would strongly recommend some genetic testing. So there's one gene that's very well characterized to cause either ALS or PSP or frontotemporal dementia, all within the same family, called the C9orf72 expansion. There are a few other genes that can cause symptoms like PSP or can resemble Parkinson's or frontotemporal dementia. The bottom line is, if you're under Medicare, we pay into Medicare a fair amount, nowhere near as much as people in Europe pay into their health system. And so one of the decisions to, conserve costs that has been made by Congress is Medicare does not cover genetic tests. These genetic tests aren't going to break the bank. They're not going to spend down your life savings, but they're not cheap. They could be a few $100s per test. But look at it this way. Once your loved one pass away or you pass away with PSP, there's no way to go back necessarily and get that genetic test and find out if you had one of these mutations. And then other family members aren't going to know if this gene was in the family. So that's the reason to pay for it, because I guarantee you maybe not in my generation, but maybe in your grandchildren's generation, there will be breakthroughs with each of these genes where knowing the gene will lead to a preventive therapy. And if you don't do the genetic test in your generation, they're going to have to wait. They may have to wait another generation or two to find out who has it. And they may actually get the disease when it could have been prevented because the breakthroughs were already there. So that's where hope through research comes in. So there are two main areas are more accurately diagnosing PSP and finding better treatments where I think there's been a fair amount of progress. But first off, what do we know about the cause? So about 10 years ago, we started to see some results from people who donated their brains for PSP research through the Cure PSP Brain Bank, where there are about 6 different gene variants and mutations that were slightly more common in people with PSP. So not everyone with PSP has these, but they're important clues that scientists are now working very hard to better understand what they all mean. One, for example, if someone has this variant, then toxins in the environment may be then converted to something that starts causing PSP. So that's one example where it's not just a gene, but something in the environment that has to cause an illness. But we're a long way off from understanding exactly what the toxins are and what are all the gene, kind of variations in your genome that can lead to PSP. Still very poorly understood. One of the main things in development to improve diagnosis of PSP, but also Alzheimer's, is just like we have PET scans for Alzheimer's, we have the amyloid PET, we have the FDG PET for dementia. There's one specifically that can bind the tau protein and cause it to light up in your brain to tell us if it's one pattern, it could fit with Alzheimer's, and potentially another pattern might fit with PSP. This looks like it's really promising in classic PSP, what we call Richardson syndrome. But we also need to see in people who have the unusual forms of PSP, how accurate is it in kind of telling us early on, this person clearly has PSP, even though the symptoms are unusual. So there is a study that's enrolling people towards the end of life with any neurodegenerative illness to better validate this ligand. It's from a company called Life Molecular Imaging. And you can kind of look them up on their website and figure out if there's a center near you where you could participate. So this past decade and a half, we've had a lot of disappointment in terms of trials that were not effective for PSP. So CoQ10, I was directly involved in a study of davunitide and then also a study of an antibody that's supposed to bind the tau protein and prevent it from spreading from one brain cell to another. But we have a couple of new types of treatment that are in clinical trials that are currently enrolling. So one is from a company called Amylex, and you can go to their website, just the amylexpsptrial.com to learn more about it. Another is called a company called Ferrer. And they, if you search for Prosper PSP trial, you'll find this one. Each of them have at least 4 centers that are actively enrolling, and they're adding more centers by the day. So if you have a center near you, or at least within a day's drive, then you could potentially be involved. Most of them will only enroll you within a certain period of time of diagnosis, like 5 years. And if you could still walk at least 10 feet without direct assistance. So for someone who's completely wheelchair bound or past the 5-year mark, then these type of treatment studies just may not be for you because you're too advanced for them to determine if it slows the progression. There are other trials I can't talk about yet, but I can tell you they will soon be listed on clinicaltrials.gov. So that's always the best place if you want to see all the enrolling studies for a given disease state. Now, another important problem is, especially with the unusual presentations of PSP, our confidence in the diagnosis can be lower. And so unless you participate in a brain bank where the diagnosis is confirmed after life, then your family will never know for sure what you had, and neither will your doctors. And the Cure PSP Brain Bank gives everyone an opportunity to participate as long as they do the groundwork of going to the Cure PSP website. It's not as easy to navigate as some websites, but if you really look for it, there is a brain donation program. There's a number to call if you have questions that's on the form. And then if you submit the form and arrange with someone local that can then basically ship the brain to Mayo in Jacksonville, Florida, then you will get a definite autopsy report, and then also can be involved in research like the genetic research I alluded to before, getting to the bottom of what causes PSP. So don't be disappointed if your local brain bank can't enroll you, as long as you can still sign up in advance for the Cure PSP Brain Bank. I also want to point out anyone with atypical Parkinsonism of any of the acronyms out there can participate. So it's not just for PSP, but for all the atypical Parkinsonisms, DLB, MSA, CBD. So even though PSP is a prime of life disease and unfortunately can often strike in our 50s and 60s, it's probably even more common as we get older. And again, this is only in Sun City, Arizona, but one of our recent papers estimated as many as 700 per 100,000 people population in our part of Phoenix are diagnosed with PSP at end of life, although those are people that are in the brain bank, many of them because they have a neurodegenerative illness. But it's likely underdiagnosed and a lot more than just 10 per 100,000. I can't emphasize enough the role of the movement disorder specialist, or at least a very experienced neurologist that takes the time to do a detailed history and exam to make the diagnosis. And don't believe the hype if someone tells you that other tests replace history and exam and rule in or rule out PSP. And make sure to build that multidisciplinary care team and that all your clinicians are copying each other in on their notes. And finally, I really encourage you, even though you're unlikely to benefit directly by being involved in PSP research, if we really want to help our kind of grandchildren's generation live a much healthier life, now is the time to really get involved in research for the conditions that we do have, to really hasten that research. So maybe it'll actually benefit our children's rather than our grandchildren's generation, even if it doesn't help us directly. All right, so I always try to leave plenty of time for question and answer. There was a lot to cover, but we still have a full 12 minutes. So I'm going to open the floor for question and answer, and just really want to thank all of you at PMD Alliance for the opportunity to kind of share this information with everyone in the caregiver patient audience about PSP. Thank you.
Thank you, Dr. Shprecher. A lot of information, and obviously a lot of these symptoms overlap. So I think there's just some questions around, I guess, clarification. So when you're talking about some of the gait differences related to falls, when someone with PSP falls, are these typically just falling down flat, falling forward, falling backwards? How does that present?
So I have a video I sometimes show people to kind of teach about PSP of this guy trying to explain his experience. And he's like, I don't know, I just lose my balance and fall. So sometimes it's not always clear, but it seems mainly to be impaired postural reflex, meaning, if you slip on a little bit of water, you and you have intact postural reflexes, then your other foot steps out, if you don't just go right on your butt right away and then catches you. That's the postural reflex. And that's very much impaired with PSP. Sometimes it's just on a turn, you lose your balance and fall, but very often it's that just something causes the person to lose their footing. They can't react in time and they go down. So very often that's backwards. So we really kind of coach people. They should have someone spotting them if they are going to be walking and trying to get down into a chair, have someone spot them getting down into the chair. People have trouble kind of slowing their descent into that chair. However, if someone has severe gait freezing, then it can be a combination. They freeze up, they can't make that turn, then they lose their balance and fall. So it can be a combination of the two.
And then there's gait freezing and Parkinson's. So how, I guess if it's just how the disease was initially presenting is how you can kind of differentiate between the two with the
Yeah,
gait
so
issues.
yeah. So again, Parkinson disease is a diagnosis of exclusion. So if you have severe gait freezing, unless it goes completely away once you start carbidopa-levodopa, or dramatically better, if you have severe gait freezing or severe postural instability with falls in the first 3 years of illness, that is a big honking red flag. This is probably not Parkinson's. And it's up to the experienced neurologist to think about the other potential culprits. And then they have to go through that whole algorithm and figure out, well, what are the other red flags? What are the things on the exam that point to PSP? And there's this rare variant of PSP where the main problem is just severe gait freezing from the beginning and very little else. But then over time, people start to evolve some subtle difficulties with slow eye movements in the vertical plane, and then also the kind of Parkinsonian kind of slowness of movement on the exam.
So the dementia in PSP, can you talk about how that presents compared to Parkinson's disease with dementia or Lewy body dementia?
Hmm. Yeah, with PSP, you know, most people don't have dementia in the beginning. They, however, if they do detailed cognitive testing, or sometimes you just ask them about it, do have problems with language. They may also have problems with what we call executive function or multitasking. And a subset may also have problems with kind of changes in behavior or being more impulsive. But it's not a memory problem for most people. And so the memory enhancers we might use for Alzheimer's or Parkinson's related memory loss are generally not effective and really don't have much of a role in treating the cognitive symptoms of PSP. But it can take many, many years, sometimes towards the most advanced stage, before the cognitive issues of PSP are really interfering. What can be frustrating, though, is there's also this slowed processing speed, and it takes a lot longer to have a conversation. So that's where, having an experienced speech language pathologist can be very helpful because they can give you strategies of how to better communicate common phrases if we're getting to that point.
You brought up a couple of things that are obviously helpful managing some of the symptoms at the time of designation and diagnosis of PSP, like speech therapy, physical therapy. But you also brought up, the fact that this disease has a bit of a faster progression. And
Yeah.
honestly, when you broke it down from, time to diagnosis to time to probably needing a wheelchair and, how it moves from there. What do you typically do as a treating physician to support and help people that are being diagnosed and their families navigate that? Because not only is it something major from a practical standpoint of, oh my gosh, now I have like this time, I got to figure out how to, put all my things in order, but like just coping with the diagnosis and the grief around that. Is there something that your center does or that you're seeing as standard of practice to kind of help that? Because with Parkinson's, you have many years typically to
Yeah.
navigate this journey, but with this particular diagnosis, it's not the case. And so that can be pretty overwhelming for people.
Yeah, I agree. So I think many centers consider social work to be an integral part of their practice model because social workers, they can kind of help talk through how you're coping with a tough diagnosis and talking through what resources are relevant to you at each stage of the illness. I know everyone has their different preferences though, and sometimes they prefer to get this information mainly from their own social networks or from the support groups like are offered through the Cure PSP Foundation. What isn't uniformly available in North America, though there are some exceptions to that, is kind of a palliative care approach. When someone has very advanced Parkinson's or an atypical Parkinsonian disorder, having someone, for some people it's a clergy member or religious figure, but for some people it's just a psychologist, a support group leader, close family member. But to have that support for the caregiver to talk through challenges as they arise. And different locales may have grants that support that type of kind of monthly check-in through a palliative care program. It could just be by phone, for example. That's something we have in Arizona through a grant. But it's still not necessarily the comprehensive type of clinic that, say, you have at Rush University, among many others, UCSF and California, San Francisco. Some of them have these comprehensive palliative care programs that we just don't have in Sun City and other places. It would be great if we did. You had a couple other questions in the
Mhm.
chat. Would you like me to speak to those as well?
Speak to
Um,
those if you can
okay,
real quick, and then I
real
had
quick.
one that direct
Okay,
message came to me, so address those
okay.
first.
Yeah. So first of all, we don't know if any drugs actually slow PSP or Parkinson's. So the reason to be involved in a treatment study is not necessarily that you expect to benefit directly by being in the study, but because these studies can really take a long time to find something that works, to provide hope for the future that there will be something that actually slows progression. So I can't emphasize enough, it takes a special kind of person to be in those studies because it may not benefit you directly. With this testing of blood or spinal fluid, there's a lot of work being done, but none of the tests, when it comes to showing the misfolded tau protein, are yet at a point where they're ready for prime time, either blood or spinal fluid. However, there may be a spinal fluid test that comes into more common use for the synuclein protein very soon.
All right, and so I had a message came in as a speech and language pathologist that's watching today. I would like to stress one, how important good oral care is for people with PSP and how speech exercises can help the muscles we use to cough with functioning better. Very important for this population. Could you comment on that?
Yes. Yeah, so this is where I can't emphasize enough. PSP care is really multidisciplinary, and allied health professionals are such an important part of the team, especially when it comes to speech therapy for both the swallowing problems and the voice and the language problems as well.
Well, I want to thank you so much for this wonderful presentation, giving us a deep dive, and for explaining things so eloquently and understandably and answering all of our questions. So I am going to invite everyone to give you that wave of gratitude from across the country. And then also to those that are watching today, we did drop some links in there you may want to grab later. So if you want to save your chat, you'll be able to navigate back to those and grab those. I know that some of the resources, some of the things that Dr. Shprecher was talking about has been listed there. So if you don't know how to do it, it's in the little box and it says the little three, I think this is the right place. They've changed it. Yeah, little three dots in your chat box. If you click the box up, the first thing that pops up is save chat. So that's how you can do that. So I want to thank you so much, Dr. Shprecher. This has been wonderful. Appreciate your time.
All right, thanks so much for having me. Take care.
All right. Thanks, everyone. Have a great day.
Bye.